Good afternoon, everybody. Welcome to SEVA VentRounds. Today, you'll see it's volume control. Uh, and it's December 14, 2021. So the disclosures is that we talk about ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion, either Rob's or mine, and it does not represent the Cleveland Clinic. I do get royalties from books, chapters, and lectures. Rob also gets some royalties, and he's consultant. Here are the ground rules. These are recorded sessions, so just mute your microphone. I may call upon you for those that are connected to share their voices. And then we can use the chat function in WebEx to do this. To just whatever questions you have, comments, that's the way that we learn together. So yesterday, as I was walking through one of our units, every single patient that for a row, it was probably 4 or 5 patients, were on volume control. And so I stopped by, I took a look around, and I took pictures, and I decided that it would be a good idea for us to review this and go through it and see if you notice some aberrancies and challenges as we go through this. So I will ask the audience if anybody's interested on reading this. Any of our fellows wants to give it a try?
Can you hear me, Dr. Mireles?
Yes, I can. Go ahead, Udi.
Um,
Thank you.
so this is volume control that for the tag. Look at my flows, and it seems volume control CMV, because I don't see any any spontaneous breaths. The time seems to be pretty equal. So I'm gonna say VC-CMVs. In terms of load, going very systematically, if the control variable is flow, I'm going to look at a non-control variable, which is pressure. And looking at the usual thing, I think the load is probably a compliance, elastance load. In inspiratory and expiratory is the same. In terms of PMAS, the hump on the inspiratory limb, in terms of pressure, not sure what to make of the hump. There could be a little PMAS in there, but I cannot be completely sure. I'm talking about the inspiratory limb of the the ascending limb of the pressure waveform. In terms of trigger, I think it's normal. In fact, in terms of whole PV discordance, I don't think there is any, because I don't see too much of spontaneous breath. So I would not say that there is a whole lot of PV discordance there.
So no PV discordance at all? Or some or none? I mean, I'm trying, is there PV discordance? Udi, any patient ventilator discordance, yes or no?
I'm gonna go and say no.
Okay. Alrighty. So let's go through this together, okay? So you read this appropriately. What do you think about the flow waveform? Let's ask you about this.
It's I think supposed to be I would think that there's thought to be a square waveform with a slight ramp.
What do you mean with a slight ramp? That's what you see, or that's what you would do you think that it should be? Can you specify a little bit more? What would you expect on the flow waveform in volume control? Anybody?
I think it should be a square waveform. I think that's what it's set as.
Right, you should see a square like this, right?
Right,
Uh,
right.
I mean, a nicer square, not this crappy square. It should go up like that. And instead of that, it takes some time to get onto the top. You see that?
Yes.
That's kind of atypical, not normal, not positive, not a usual thing that you would expect here. So this is one of those things that even though this is volume control, uh, every single flow that was delivered here looks exactly the same, and so that is the hint that that the flow is being controlled. If this was pressure control and the patient, that would mean that the patient would have been doing a lot of effort, right? Instead of this square that I really butchered here, let me try to make a nicer square for you. If this was pressure control, I mean, if this was volume control, it would look like this, a nice square. Okay, that's better, I guess, or I'm just applauding myself. If it was pressure control, it should go down like this, right?
Mm-hmm.
In an exponential descending.
Mm-hmm.
And if that's not the case, this would all be effort, and then you would expect changes over here or any evidence of PMOS, and every single one is the same. So this definitely is volume control. The challenge that the manufacturers did is that they added a value that is called rise time.
Mm-hmm.
And that rise time is the time that it gets to get to peak flow. And whoever programmed this ventilator, for whatever reason, decided to change. And instead of going in a straight up, that would be the fastest way, they put a little bit of delay on the time that it takes to to reach peak, which makes no sense, no difference. This is a something that was just programmed. So that's why the curve doesn't look like a square as you would expect. Somebody set that up. Okay, does that make sense, Udi?
Yes.
So in this type of ventilator, this is a servo U. You can set the rise time. So this is called the rise time. And then they also decided that instead of having the ability to um, to do a square waveform, they also wanted to allow you to make a descending ramp. And there's another way that to set the descending ramp here, which is to set the percent end expiratory flow. So essentially, you can, instead of choosing like in other ventilators, just you choose either a square or you choose a ramp. In this ventilator, you choose the value at which this is gonna end. So it may pick up, and then it may end up here, 40%, or you can put it to 0, or you can put it to 50, whatever number you want. What's the use of that? Beats me. It has no clinical use. Why would you do this? Apparently, I don't know of any research that says that one is better than the other, and I'm really open to hearing on this. The same with the rise time. I don't know why would they do that, but I would just put that there for you to recognize that whenever the people you are in volume control and somebody changes the rise time or changes the end expiratory flow, what you're gonna see on your pressure waveform is gonna be modified, and it's not gonna look the same way that you expect to see it. Normally, what you would expect to see on a patient like this would be I'm gonna do it on this one so that there's no glare. This should go up rapidly, and then it should go like that. That's what you would expect to see, a straight shoot offshoot, and then the compliance part, which is the slope of the curve, because they change the rise time. This doesn't raise as fast as it should. Does that make sense, Uri?
Yes. Have in your experience, do you think there is any truth to the fact that because I've discussed this with the respiratory therapists, that normal human beings, functional people, it's not an abrupt flow in and flow out. So a little bit of rise time or in exponential flow is more comfortable. Any comments about that for the patient?
I think that's. Do you see any evidence of patient activity here?
Yeah, true.
No, right?
Yeah.
So that's that makes no sense in the book. Now, if you're talking about somebody that is in spontaneously breathing, it may depend where the patient is and how they are asking for the flow, and there may be some role to adjusting the rise time in patients that are spontaneously breathing, in which they are in pressure support or any of these modes. But otherwise, in a patient that is passive, as this patient, that makes no sense. That theological thought of humans do not breathe that way doesn't carry any background that I know of, and I'm happy to be shown otherwise. I've looked for it. I have not found any. So at least on volume control in a passive patient, it doesn't make any sense. How about that? Let's settle that. You're in agreement with that?
Yeah, absolutely. Thank you.
All right. Now that I have redrawn the waveform, and you see this huge step up, right? Very large step up on the initial pressure, and then the rest. What does that still make you think that this is elastic or resistive?
No, I think I think there's resistive there, probably because the initial spike is quite high.
It's quite
So
high, right?
yeah.
Yeah. And then there's other hints that is there any other hint that you or anybody else on the call sees that about an increased resistive load?
Expiratory time, maybe it doesn't reach the expiratory flow doesn't reach the baseline completely.
Yeah, excellent, Udi. So you're starting to isolate that the time that, I mean, you don't see any PMOS, it's exponentially decay, and it takes probably around 2 seconds to get all the way to the baseline, and it's not even close to that. And so that makes you concerned that there's a resistive component here. Uh, that it's aligned with what I'm showing you here now. So I would think that this patient has likely a resistive during inspiration and resistive during expiration. Now, I'm a little bit evil, and I left here the dynamic compliance. You saw, is that what draw you to the elastic load being high?
Partly, but the peak is also pretty high.
Yeah, remember that the peak pressure on means nothing on volume control unless you because it can be all resistive, or it could be compliance and resistance, right? So
Yeah.
it can be both at the same time. Very good. And then in terms of PV discordance, I agree with you, Udi. I just wanted you to say it. I wanted you to there to just calm down. If there's no patient, there can't be any discordance. I mean, there's no discordance. There could be false triggers, but in this case, there's no activity at all. So this is consistent with a patient with increased resistance uh, uh, during inspiration and during expiration. He may have decreased elastance. We need to see that better, but because we affected the rise time, it actually hid my ability to see things clearer. Uh, and so I wanted to show you this. So as you know, we can do an end inspiratory pause, and Haura put that on the chat. She says, well, you need to do an inspiratory pause. So here is the same waveform, and now this is a little bit the time is a little bit prolonged. So this is 1 second. So you can see we expanded and it's easier to see the waveform, and now it doesn't look like a square. You can see that here, and so this doesn't rise immediately as it should, and this should be a straight line all the way over here. But you can actually see that when we do an inspiratory pause, so we know this is an inspiratory pause because there's no flow around here. And during that pause, we see no change in volume, obviously, because there's a pause, and we don't see any change in the pressure, which is good. That says that there's no PMOS. The patient went down, but you can see how much it went from up this point all the way to this point. And so all of this difference, this is the elastic load, and all of this over here was the resistive load, so resistive and elastic. And you can see that the one that is beating or that it's larger than the other one is the resistive load for this individual patient. And I put over here this rise time that I told you about, and you can see how it can change the rise times for the flow as discussed previously. Questions? Comments? Anger management, sadness? So an interesting waveform that as you're walking by, you see this, your thought is, well, why does this patient have increased resistance? Make sense? All righty.
Hey, Dr. Morales, this is
Yes.
here. Just a question, and I'm probably overreading this one, but are there any sort of, I'm seeing some vibrations in the expiratory limb. Would there be a component of secretions there, like these expiratory oscillations?
These ones? These little things that I'm putting with an arrow?
Yeah.
Yeah. Those are yeah, it could be secretions, it could be heartbeat. I usually try to see it if it happens at this exact same time as you, and you can see that it's occurring practically at the same time. It can be secretions. It can also have a rhythm, and it can go with the heart of the patient. So sometimes increasing the gain will give you a little bit more evidence and desire on what's going on with them. Yep. Thank you, Samit.
Would a small
Very
ET
good.
tube represent this kind of scenario too, for the resistive inspiration and
Yeah.
expiration?
Absolutely. So the theology is here, and I can tell you a little bit more about the background of this patient. This patient only had an elastic component, and then suddenly the resistive component went up. And so the causes for that in a patient that is intubated that didn't come with obstructive lung disease are, as you point out. So one of them is a obstructed tube, and the obstructed tube can be because the patient is biting, or it can be because he has a mucus plug, or because it's kinked, or because somebody left the suction catheter inside, or because it's just a small tube, without a doubt. Small tubes can also do that, and it may. And actually, it's a really important thing if when you think about that and you're trying to wean a patient, and this is a small ET tube, and you're seeing this amount of resistive load, and then you try to do a weaning trial for a patient with a small tube, the chances of that patient doing poorly are going to be high, right? So great point. Sorry, I changed the slide. All righty, very good. Any other questions? Okay, let's move to the next one. Anybody wants to try this one? And before, not this one, this one. Have no fear.
Dr. Morales, I can take this one.
Who's this?
It's Michael.
Okay, Mike, go for it. Thank you, Mike.
All right. Sorry, we're trying to mute the fellow room a second.
And as I said, I have said before, this is, I know that sometimes it becomes anxiety provoking to be talking in front of everybody, but just remember, we're all learning here. We learn every time we do one of these. And you guys know and learn more every time you step up. So thank you for doing that, Mike.
Of course. Sorry, Prince, can you, he's on speaker over here.
Okay.
Sorry, we're just dealing with some of the fellow room technical difficulties. So the tag to me appears to be VC-CMVs. The
Okay.
load appears to be primarily elastic to me for both inspiratory and expiratory. I don't see any evidence of PMOS. And then there's no real patient effort that I can see and anywhere. So I would say that, the trigger is normal, inspiration normal, cycle normal, expiration normal, and no patient validator discordance.
Excellent. Very good. So you see how fast it was, Mike? High quality
Yes.
care. So let's talk about this a little bit. So you again recognize the VC-CMV. Now you can see the difference between this waveform, the rise time is immediate, correct? And the end value is 100%. The end expiration is 100%. So it's a square waveform. Now, many of you have heard me say this before. In normal circumstances, or in most ventilators, when we see this is actually a square. It doesn't have these little irregularities on top, and this is just something that the Servo U does, and it does it when this button is on, which is or when this little icon is present. And so these are a circuit compensation that is active, and it will modify the flow waveform to demonstrate irregularities that they are calculating from the airway that they think is PMOS or PMOS or changes in flow. So doesn't mean anything. We can, if you click this icon right here, it will tell you if you want to turn off the circuit compensation, you can turn it off and this will disappear. Do you need to do it? No. But it's just something for you to be aware of, that if you're seeing and you're having some issues reading the waveform, sometimes getting that off, and you turn it on. You have to go to the menu and turn it on. It can be turned on. So that's why you see these irregularities here. It doesn't mean PMOS. Remember that we're controlling the flow. So we go up and look at the pressure. Whenever you're controlling the flow, you look at the pressure waveform. And so what made you think that this was elastic, Mike?
So the slope of the pressure waveform is incredibly high, and it almost seems to like there's a curve in the first part of it, which I think is alveoli distending, and then eventually reaching a point where it completely slopes up.
Yeah, good observation. So if you think about this is the flow that is being delivered, and this is the change in volume, right? So you can see the change in volume occurs relatively rapidly. The I time is set probably at 0.5 seconds. But as the flow is being, the volume is going in, the change in pressure is manifested in this slope, the slope of the pressure waveform. So the higher the slope, the lower the elastance, or the higher the elastance, or the lower the compliance. And if this had looked like this, that means that the elastance or compliance is better instead of looking this high. So this rise this way is a good marker of increased elastance or decreased compliance. And then the other, you see this is the step up that occurs in terms of the resistive load. It's this little initial, actually you can see it very nice there, the change in slope. This is the point where initial resistive load occurs, and then it goes all the way to the top. So when you see that, it makes you, now you know how much of the resistive component exists. So this is the amount of resistive component, and compare it to the amount of, so if I put that same amount over here, and then over from here all the way to down here is the elastic component. So it's huge. It's a fair amount of elastic component versus the resistive component just by looking at the waveform. And then during expiration, what made you during expiration think that this was an elastic component, Mike?
Kind of the same thing. The decay is really quite quick to get back. I know there's a little bit of portion there that doesn't completely get to baseline, but the flow drops pretty quickly.
Yeah, so this is 1 second, and you can see that it essentially reaches by 1 second, it has reached zero flow. So those are features that they're concordant with what you're seeing over here and would make you think, this patient has very low elastic load, or very low compliance. And then you said, I don't see any PMOS. So whenever I'm looking at for PMOS during inspiration, I look at the pressure waveform, and I agree with you. I don't see any change before the trigger occurs. There's no change in pressure there, and I don't see much change on the flow. There is some beaking, so meaning that there's some concavity at the in the inspiratory portion that makes me think that we're over distending some parts of the lung at this set tidal volume. And then during expiration, because in expiration we control the pressure, I look at the flow waveform. And in the flow waveform, I see a repetitive kind of kink, this little kinky thing here. There's another one there. Normally, if this was an inspiratory effort, that could be an inspiratory effort, but it's very regular. I'm not sure of what I'm seeing, and I don't see a good concordance with anything here. And there's something here. So it could be in effect, a failed trigger. You would have to take a look at the patient and see if that's it. Sometimes you can do an end inspiratory pause to see if you see any evidence of PMOS on this patient, but it may be too regular, and it may be related to either the heart or airway. I don't see much else there. So I cannot really say that I see much of a PMOS, and perhaps, if anything, failed trigger, but I would read it like that. Which I think is what Tim Howell is putting there. There's a dip in the flow below baseline. Right here.
What would cause that dip in the flow in that first waveform? Because my first instinct is the patient's drawn in on flow right as inspiration starts to the right of where you're looking. That first.
Right here?
No, to the right of it.
Right
there.
Here?
Yes.
Yeah. So if he was trying to breathe in, then this should cross up.
Oh, okay, that makes sense.
Yeah. So anything below that is air going out.
Yeah.
And so this is
And then that on the volume, the pressure waveform, there's that almost looks like a dichrotic notch as the flow. What would that represent? That little blip there.
Yeah.
Why is that?
So when the machine cycles down, so there's a couple of things. Normally, what you would expect is that this would go all the way down, right? It should come here and it would go down to PEEP. It doesn't always do that, and there's two things that I see. If this comes out very high, sometimes you can see it from higher. That makes me think that the expiratory valve is not working. When I see it this low and repetitive and with not other, it makes me think that that's part of the algorithm. And we have seen that. I'll show you the prior one. So look at this one. And we have discussed this in the past, in which the ventilator is trying to get you back to PEEP without crossing it or back to it the fastest. And they have created an algorithm that they put a fancy name to it to try to get you there the fastest. And sometimes it works well, sometimes it doesn't. And so I presume that that's what we're seeing here, that you're seeing the machine saw the pressure drop very fast, and it said stop, or we're gonna overshoot, and he's gonna be he's gonna lose a lot of PEEP. So it may be the algorithm. Yeah. Cool. Does that make sense?
Yeah, it does. Thank you.
No problem. Any other questions from the team?
Dr. Mireles, I was also thinking the same thing, in which that I was trying to correlate if the notch, the dichrotic notch, as was discussed, as well as the flow limitation on the flow. And I was thinking if this could be expiratory valve. So if there's an expiratory valve problem, you showed us how the pressure waveform would do, but the flow waveform, would it be like, what would that look like if there was an expiratory flow problem? Would it also be like it looks here? Would it look like this, like a resistive load in expiratory limb?
Yeah, we actually did a very nice, that was Matsuba. We had a couple of cases, one reported by us, and the other one was a Twitter submission that demonstrated the flow waveform. So if you go back into the YouTube chapters that we have, you're gonna see one that is called expiratory trouble. And Matt describes what we saw there very nicely. There's two very nice examples of expiratory flow valve failure. Okay.
Yeah, thank you.
No problem. All righty. Excellent. Great job, Mike. Good reads. Thank you for the questions. Let's do another one. Now, anybody wants to do this one? Have no fear. Come on, fellows. I know you're in the room looking at each other saying, I don't want to. You know who I have never heard? Prince.
Prince is on service. He's on Navy. I'm not sure if he can hear
He
us.
ran away. All right.
I can take a stab at it.
All right. I'm gonna call you Prince for today.
All right. I'm not that handsome, but we'll give it a try.
Go for it.
All right. So it says volume control up there, and with the circuit compensation there, then maybe we're dealing with a volume control and a decelerating flow pattern. So VC-CMVs. And then looking at the load, I think the load is primarily PMOS. Looking at the pressure waveform, I'm gonna try and look at the first waveform and see if I can maybe get anything out of it, but I think it's challenging. So I would say PMOS. And then the expiratory load is PMOS as well. And then in terms of PV discordance, trigger seems to be appropriate. It's flow triggered. And in terms of inspiration, there is significant work shifting. And then in terms of cycling, I mean, there's an inspiratory effort in expiration every single time. That's almost a failed trigger. It is not very proximal to the end of the breath, but as well, if you look at the peak expiratory flow, is variable, which makes me feel that the PMOS is going from inspiration bleeding into expiration. So I'm gonna go with early cycling here. And with trigger, we might as well add some failed triggers. Now, it's not hitting the baseline, but the patient is clearly trying to inhale and he's not getting the breath. And then expiration, there is expiratory work, possibly. Looking at the volume waveform, the first one, maybe there's some leak, but I can't tell because I don't see the full breath right before. But yeah, that area there might be concerning for a leak, but it's not very consistent, so who knows what was happening.
Yeah. All right. Excellent. Prince Ahmed. How about that? Is there any circumstance in which you think that this is good?
That this is good?
No.
No, I mean the work shifting is like, if I am gonna have the patient do all this work, then I, like having pressure support. But obviously, looking at PEEP and the FI2 looks like he's not ready, so I need to kind of relax him. or knock him out, basically. One thing that you can think of is, PAV with servo, but my expectations will be it's going to get higher volumes than what we want if we do so. So maybe we're at safety at this point. We're trying to limit tidal volumes. I'd rather try and abate the patient respiratory drive.
Yeah, thank you. So this is one of those screens as you're walking that needs to stop you on your tracks as a fellow and say, what are we doing here? How do we correct this? And not everything means sedation, but you have to be clear on what your goals are. And as you pointed out, 80%, 16 of PEEP, it's hard to make an argument for comfort at this point, but it may be a morbidly obese patient with a shunt in the heart. I don't know. And then you want to keep him awake. Fair enough. But then in their circumstances, this is the inappropriate mode. So this needs immediate attention when you see one of these waveforms. Even if it's not your patient, just stop and grab the first respiratory therapist available, or physician or human. Yeah. I can imagine. So Haura Halal says we're having similar waveforms during our crisis in Lebanon with the unavailability of paralytics, and under those circumstances, you have to say, well, what do we do? I mean, if this patient is working against the ventilator, and it's probably gonna I mean, he's trying to trigger even more breaths than what he's getting. Really challenging. So let's take a look. Let's go. So definitely volume control, and you picked up a appropriate, I mean, perfectly on this, Ahmed. This is their circuit compensation. That's why these waveforms don't look the same. But even in the presence of very high PMOS, there is no, the volume remains close to target, and you can see it here. I mean, for each breath, the patient is getting his 446 in spite doing a lot of effort. So I think that this is a construct. In this case, the patient again has a very rapid rise time, and whoever set the ventilator probably set it up to a descending ramp, so going all the way to 0 on the expiratory flow, or even less. We'll see. PMOS throughout. In this breath over here, it's the only one that you were trying to see if you could read what the patient physiology was. And it was, I mean, the patient triggered, but it's hard to say because you can see some evidence of so you don't know if this is PMOS or this is if he was taking a breath here or here. So it's hard for me. So I would stick with what you said, PMOS. And there's severe work shifting here, as you pointed out. This is all markers. I put this as the baseline. All this area that I'm putting on yellow is areas of work shifting because they're severe work shifting. The one that we suspect that hurts the patient. So the trigger seems to be normal for the breaths that the patient triggered. But as you pointed out, there is evidence that the patient is trying to inhale at a faster rate that the ventilator is capturing. And so these sometimes, this can be a failed trigger, or it also, and we have seen this, is that the patient is actively exhaling. So it goes from inspiration to expiration, then it relaxes, and then it tries to exhale again, and then inhale, and it keeps going back and forth. But just by reading this waveform without being able to see the patient's dynamics, this would be what I would I agree with your failed reading, and this one as a normal. We talked about work shifting, very severe throughout the 3 breaths that are present here, with no change in tidal volume, which tells us that this is volume control. I agree with you in terms of the cycling. There's some features that make you think that there's early cycling. The flow, normally the flow should look like this one, right? I mean, like this, and it should look something like that. So you don't see that here. So it makes me think that the patient was still inhaling at that period of time, here and here, and then tried to exhale, shift directly to exhalation. So I'm in agreement with your reading of that this is an early cycle. And then there's evidence of expiratory work throughout. So a patient that is very active, actively inhaling, actively exhaling, with perhaps a faster rate than what you're seeing there, which should generate a lot of anxiety if your goal is safety. And if your goal is comfort, this is horrendous. You need to change the mode. So I'm going to ask those that have access to the chat, assuming that this was pressure control, and you could not use paralytics because the patient, there's none we're in Lebanon. What mode of ventilation would you use for this patient under these circumstances? Just want to hear. There's no, as you have heard me say before, there's many modes in the world you use according to what you think. So just type in what you think that would be the mode that you would put this patient. As you see it now, 80% FiO2, PEEP of 16. You don't have paralytics. You cannot sedate him further because whatever. Would you change the mode? Leave him there. Some of you may want to leave him there. Just want to get the temperature on the room. Anybody wants to chat? Put anything on the chat, or is because the chat is not available?
Are you saying if they were in pressure control, what would we change it to? Is that what you were saying?
Oh, would you change them to pressure control? Would you change them to pressure support? Would you change them to what would you change them to? So I have two people asking to, oh no, it's the same, asking to change to NAVA, so pressure control CSVR. Some people said change to pressure control or adaptive instead of set point. So I guess adaptive would take them at least to baseline pressure, but it would not be fighting the ventilator. So it would be a way to keep them at with the least amount of tidal volume possible. All right. Okay. Nice responses, team. Okay. It's 2:44. We have one last one, and actually it's the same patient, but I was walking away, and then he did this, and I came back and I took a picture. Anybody wants to read it? You already know what the tag is because our friend Ahmed read it. I'm wondering if anybody wants to read this one. Any of our fellows wants to jump at it in the fellow room? Come on. I'll put the tag.
Sorry, we're having technical difficulties. I can do it.
All right, thank you.
After you gave me the tag.
That's okay.
Okay, so obviously VC-CMVs. I don't see, I mean, honestly, everything is PMUS for load in both directions. Trigger. I'm going to go late trigger because I'm seeing some decrease in or I guess a pull down of the waveform before the machine triggers the breath. Inspiration. Definitely work shifting and inspiration. Late cycle. It looks like the machine is, oh, sorry, early cycle. because the machine is turning the breath off before the patient is ready to fully expire. And there's definitely expiratory work shifting.
All right. Woo! This is, thank you very much, Marina. So absolutely VC-CMVs. However, this is what stopped me. I mean, there were several things, but this is, so look at the inspiratory time here, inspiratory time here, inspiratory time here. Look at the inspiratory time here. Short, right? Shorter than these three. Why is that? Anybody? Why is the I time shorter here? It shouldn't, right? It should be the exact same because all the breaths are mandatory. Why is this one shorter?
Because they inhaled early. Took a breath in quick.
Okay, that's one possibility. The key to the question actually lays on the screen in this little box over here. So what happened? Yes, it hit the peak pressure. So whenever you hit the peak pressure in this ventilator, you're going to get this little reminding you where the alarm is. Actually, you can see the alarm is set. The alarm is set at 5 and 40 for the respiratory rate and the peak pressure at 50. So it got cycled off early because it hit the peak pressure, and so the I time was shortened because of that.
Perfect. That's cool.
Yeah. So that's what shortened it. So I immediately I said, oh, is this IMB? But it's because it's triggered by the patient. But I thought that was it. But no, it's because he reached a peak pressure. So let's go over this trigger. Is it late? And what you see here, Marina, is that the patient is doing more and more and more effort. I mean, every time higher effort after he triggers. And because he does so much effort, the machine is unable, even though the flow has gone up immediately, it cannot keep up with what the patient is doing. So that's why you see that immediate that drop in pressure. It's not necessarily a late trigger. Actually, if you notice the patient, if you try to match the lines, they are pretty much aligned. I mean, the ventilator is triggering. It's just that the patient is doing a lot of effort. So if you don't, that's important, at least when you're doing research. If you're doing just looking at the pressure waveform and reading it from just how it looks, may be an inappropriate read, because it may be that the patient did trigger the ventilator, but the patient is doing too much effort, like is what you see here. So in those, the triggers continues to be normal, but there is evidence of increased effort. So the patient is doing a lot of effort to trigger the ventilator. You have, again, these little suckers that we saw before that suggest that there may be failed triggers. And then inspiration, there's the work shifting that you saw before right here. There's during the initial inspiration, this is all work shifting. But there is and so that's what we saw before. And then you have the cycle. And so this is the key part, I think. Look at the expiratory, what happened here? Look at the expiratory flow. Compared to the last time, you remember how the expiratory flow was shorter, meaning that the patient was doing inspiratory effort, so it was early cycle. Here, actually, the expiratory flow goes higher with each time as we go through, and it's correlated to the time that the patient exhales. And actually, you can see this increase in pressure that is going on in the ventilator. And that makes me think that the patient is actually exhaling against the circuit. So now it's the patient is going from their inspiration to expiration. It's going out. The ventilator is not letting them, so the pressure goes up and until it trigger, and then it exhales. And so the flow, when it exhales, but from with all that increased pressure, the flow is going to be higher than what you're seeing. So it's triggering and then going directly into expiration, and you get that expiratory effort. So I think that in this case, it looks like late trigger. So this patient, in the 10 seconds that I was in front of them, went from severe work shifting with early trigger, with failed triggers, to now some work shifting with what late cycle. So this patient is completely inappropriately interacting with the ventilator. This patient should not be on this mode of mechanical ventilation at this time. Questions? All righty. Great job. As you saw, we progressed through different ways of seeing volume control and how it interacts both in an increased resistance and increased elastance and with PMOS. So this gives you the whole gamut of volume control interactions with the ventilator. And in this last one, you can see from early trigger, increased trigger effort, work shifting, severe work shifting, late cycle, early cycle, and expiratory work. So you went through a bath, you took a shower of knowledge in volume control. So with that, we're done. Thank you very much for listening to us. This is the code for the CME. And as I told you before, just send us your waveforms. This is the SEVA webpage, and whatever you need, please let us know. Excellent work.